Hello, this is Matt Link, President of NuVasive. Thank you for joining me for a timely discussion on COVID-19. Today, we hear from another global thought leader in an effort to learn from one another during this global pandemic. Joining me is Dr. Pedro Berjano, orthopedic spine surgeon and director of the Spine Surgery Division of the Orthopedic Clinic at the IRCCS Galezzi Orthopedic Institute of Milan. As of today's recording, more than 20,000 Italians have lost their life due to COVID-19, with hundreds of thousands still fighting the virus. Collectively, we can learn from Dr. Berjano and those fighting this virus in Italy. Dr. Berjano, thank you for joining us to share your experiences and your colleagues' experience in fighting COVID-19. Before we get started, can you share a little about your professional experience and a little about your practice for those listening?
Yes, I'm an orthopedic spine surgeon practicing in northern Italy, in Milan, specifically. My main focus in research and in surgery, in clinical activities, adult deformity and complex spine surgery, including revision. But I also take care of patients with degenerative spine, minimally invasive surgery. Now I'm co-chairing with my partner Claudio Lamartina one of the biggest spine surgery services in Italy.
You've been living this and experiencing this crisis real time, not as a specialist in the field of epidemiology or infectious disease, but as a provider in another medical specialty. I think that's an incredibly unique perspective for people to hear about. I'd love for you to share about your experience in living through this pandemic in Milan. And what can you share about how this played out in Italy? And specifically, what was the early response and experience like for you and your colleagues?
Yes, I think you're right. One thing that has been very unique in our experience is that we have been exposed to something which was very unknown. And this partly because we were probably the first strongly hit country in Occident after the Chinese and Singapore and Korean and Japanese foci, but it's also due to some kind of cognitive bias we have been having. And it's like experiencing what was happening in Asia, like something that would not be coming into our country or into our countries. And I think that has been a perception bias that has been affecting all the handling of our epidemics. And I tend to summarize this like saying we have been overproud and we have been thinking that we are different from the others. So that happens in China because they have live animal markets. That is not going to happen here. It happens in China because they have overcrowded cities. That is not going to happen here. And at the end, the reality is that our biology is the same as the biology of Chinese people. It is a very highly contagious infectious disease. And of course, it has been skipping through the pathways of communication of humans and is affecting all humans in very similar manner. So I think that we haven't had the rationality or the humility to understand that we were not protected. It was a belief, but it was not rational. And the second thing that we have learned with this, the dissemination patterns of this were the same as flu. For example, we know that from SARS and that from flu, people with symptoms are the ones who are going to transmit the disease. With COVID-19, we have learned that people can be asymptomatic and transmitting the disease, can become symptomatic but begin to transmit the disease days before or even more than 1 week before. We have learned that differently from other respiratory diseases, this COVID-19 disease keeps people infected, sometimes not only for 14 days, but we are seeing now data from people remaining infectious for more than 3 or 4 weeks. So this has been changing our perceptions. We thought that we would be effective preventing the transmission of this disease the same as we did with SARS or the same as we do with flu, but it doesn't work with the biology of this infection. So again, it has been our cognitive bias that has prevented us from taking the right measures of prevention.
I think that's an unbelievably valuable perspective, because I think, again, as you take a step back and you look across the globe at what the response has been, it's been a relatively inconsistent or uneven response. And I think, I guess, what's equally as intriguing here is that even in light of what you've described and the experience to date, the responses in many regions are still inconsistent. So with that context, as you came to the understanding, or you and your colleagues came to the understandings of the the differences in this virus, in disease, in its transmission in particular, share some of your learnings and how you have had to adapt in that environment. What have been the learnings that have allowed you and your colleagues in Italy to begin to bend the curve, so to speak, and start to get this under control?
Yeah, it's very difficult because in spite of being the same biology and the same virus and human biology, the stage of the dissemination of the disease is different from one to another region of the world or from one to another city. But if I have to speak about our current situation, where we have hundreds of thousands cases diagnosed, probably some million cases undiagnosed, we have to adapt our thought and our behavior to this. So one of the things that we are more worried about today is on how to be able to protect our patients without making non-infected patients becoming infected. For the same reasons I was describing before, it has been recognized that in Italian hospitals, but I think it has happened in most of the hospitals of the strongly involved countries, the hospitals themselves can become foci of dissemination of the disease. And this is because they aggregate patients with symptoms or with who are carriers of the disease. They get in contact to young people who are healthcare providers who can transmit the disease without suffering from symptoms. We don't have the tools or the ability to do testing to everyone who is working or who is presenting to the hospital. And so one of the challenges is how to protect everyone. And it's like having wolves and sheep in a community, and when you have to put patients with the virus or without the virus with some uncertainness, you have first to decide what do you want to do. If you have a ward which is COVID-free, are you going to admit there anyone who hasn't been proven to be free of that? Or the opposite, are you going to classify people to I don't know and then COVID wards? And that's very important, because it's like having a hospital where you have to take the decision whether to put one wolf among the sheep or one sheep among the wolves. And the consequences of both are severe in any case, but they are quite different. So I think that designing a clever protocol to be able to identify those patients who are free of disease, those patients who are with the disease, and to classify correctly, and to have healthcare providers who are in the same category, who have passed the disease or who are free of disease, to take care of these people is going to become very relevant. The second thing that we are learning now is that probably to restart providing elective care to our patients, we will have to do it stepwise, and we will have to identify profiles of risk that allow to provide early care, or that will imply to delay the care for some people. I mean, if we have young people who have had the disease and who are now free from the virus and who have an invasive surgery. Probably you can proceed with them right now with a little caution. On the other side, if you have elderly people who have to face complex surgery and elderly people who have not yet been through the disease, these people are going to be very critical in their handling, and probably they should be kept out of the hospital and delay the surgery until they can be treated in a safer way. So it's very difficult to identify the perfect way because we don't have all the tools that would be needed to do this. But the thoughts have to be ahead of the decisions in order to have the right decisions taken when it's the time.
In the current period, where you're still dealing with, as you referenced, hundreds of thousands of active COVID cases and many more undiagnosed COVID cases, what have been the, I guess, critical measures? Because I know despite your specialty in orthopedics, you've been volunteering and working in a broader capacity to help respond to this crisis with COVID patients. And we know that in the community, there's obviously been social responses like isolation and social distancing and other things that are keeping people apart to try to limit the spread. But as you mentioned, these hospitals and large healthcare facilities become a focal point of the disease, and we're trying to balance obviously the treatment and optimization of treatment of COVID patients, which is, our learnings are unfolding in a real-time way, and then also, as you referenced, there's other healthcare needs that have to be addressed in those same facilities. What have been your I guess experiences around things that worked, and I guess equally as important, things that didn't work that had to be changed, and possibly related to some of the biases that you referenced earlier? Again, your experience is unique in that you're on the sort of earlier front end of this, and these learnings can obviously be, I think, really valuable for other markets as well.
Yeah, but it's very difficult to provide advice to anyone because there is a huge constriction. So people cannot take the right decisions because they don't have what is needed to take them. I give you one example. If I had to take the ideal decision, I wouldn't have any healthcare provider working if they are infective unless they are working just in a COVID area. But the problem is that we don't have testing enough for all these people. And especially we don't have testing enough to repeating the test in people to understand how is going to evolve their status. So today I don't have the disease, but in 3 days' time I can become a carrier. So it's one limitation that is imposed by the biology and by the availability of instruments and of diagnostic tools. One of the things that has been most critical in the Italian experience is not being able to appropriately protect the healthcare providers. And I mean that in some hospitals, due to the shortage of high filtering masks and waterproof surgical gowns, many healthcare providers, I mean nurses and doctors, have been facing the disease with inappropriate protection. And so they have become diseased, infected, and infective at their time. And that, I think, is one of the most critical things that we have learned in the healthcare environment now. The second thing we have learned is that probably under this threat, you cannot assure the same standard of care for complex patients who face elective surgery. So I give you one example. When you have limitations in the time that healthcare providers can spend within the rooms of infected patients, if these patients need a high intensity of care, probably they will not have the same high intensity of care. And I mean, for example, rehabilitation, mobilization, the same if they need to be stuck to oxygen, or they have difficulty for breathing. So this is a very important thing. And so, but I think that most of the countries or most of the colleagues I have been listening to have understood this, and they have stopped their elective surgery, especially for complex cases. This leaves us with the less complex orthopedic surgery, for example, hip fractures. These patients are going through very tough moments because they need high intensity of care, and they have the constrictions that are brought by the disease. So there's a trade-off between doing what is ideal, or which is our normal time standard of care, and what we can provide now safely for these patients.
So with that in mind, and some of the limitations in the ability to treat these elective or non-urgent cases today, in looking forward to a period of recovery over the next several months and through the end of the year, you referenced a couple of things that are critically important, testing being one, testing for active infection, testing for antibodies to potentially suggest immunity being critical tools in your ability to manage a patient population in a more ideal manner, PPE being another critical component. And these are things that we know that, again, globally, there's a response to try to address and avail to the healthcare provider community. What are the things that you're looking at as potentially near-term or even long-term changes in how you provide care for your patient population, which, as you referenced in your background, includes a large segment of these higher risk patients that may have comorbidities due to their age and their complex spine disease. What are the things that you and your colleagues are looking at implementing on a go-forward basis?
Yeah, you're right. This is one key aspect of how is going to be the future. And I think that one of the keys is going to be what are the strategies and how effective are the strategies that the hospitals can put in place to create COVID-free areas. If they can create COVID-free pathways in a safe way, probably we will have the chance to start again sooner and to have a more accelerated recovery of the normality. If we fail due to the virus biology, due to the testing available, I have to remind you that we don't still know whether someone who has immunoglobulins in their blood to the virus is still able to get the infection again. So we don't know many things about the biology of this infection yet. But in any case, in the measure that we are able to create COVID-free hospitals or COVID-free segments of the hospital, we will be able to recover better and sooner our activity. And I think that on the other side, even we have to think that the next year or so, or better, until we have an effective immunization against this disease, probably we will have to introduce permanent changes in our lives. I think that in the surgery, at the beginning is going to be to reduce the amount of surgery on elderly people and to try to delay that. Second, to try to reduce the amount of very aggressive surgery. And I think that minimally invasive surgery can play a role here, where you can keep the patients in the hospital as short as you can, and to have them walking again and going home as soon as they can. I think it's going to play a role. Another aspect which is going to change is how we handle practice. And we need some structural changes, leave alone using the mask and the gloves when you are seeing patients, but it's also having patients coming one at a time, having enough interval of time between one patient and the other one and the next in order to avoid people meeting together in the practice. So my practice is being reorganized to admit one patient at a time with no accompanying people. No patient is going to enter the facility until the one before has been going out. So it's going, of course, to affect the fluidity of our pathways, and it's going to be a very important organizational challenge for us. And you can imagine also that this has consequences on patients' well-being, because they will have to live with their disease for longer in some cases. And it has also even economical consequences for the viability of practices, hospitals, and much of the healthcare provider system. So it's a great challenge what we have ahead.
Dr. Berjano, perhaps in closing here, we referenced at the beginning the unique perspective you have as a healthcare provider, but not a specialist in this field as it relates to infectious disease and all the learnings that you've gathered. Perhaps for the broader audience, I mean, what are your key takeaways as you think about, again, over time, a transition back to a more normalized practice? What are the unique perspectives you think you'll carry forward in the care of your patients and as a provider, to the overall community?
I think that what I would suggest my colleague to do is to take paper and pen and begin writing how they are going to behave in the future. Because until you imagine how is going to be your practice, how is going to be your organization in the OR, how is going to be your traveling to the hospital every day, and you write rules, you will not have a clear picture on how to deal with all these problems. And many of us have the not only the right but the obligation to dictate rules on how to take or retake the activity. So my advice is take today paper and pencil and begin writing the future, which is also some kind of optimistic message.
Pedro, in closing, it's been an honor and a pleasure to speak with you. I can't tell you how much we appreciate you, your colleagues, and healthcare providers around the world who are fighting this crisis. So again, for myself and on behalf of NuVasive, I just want to say thank you. It's been a pleasure to speak with you, and we hope that you and your colleagues and everyone continue to stay safe and healthy during this ongoing crisis.
Thank you, Matt. And I could not say goodbye or say bye to you without underline how this apparent sense of duty that have had the healthcare professionals is the same that the people providing assistance from your company to our work every day have been having from the first day of this epidemic. So I'm very grateful, and I think that patients probably don't know that behind the doctor there is also a big supporting team which you take part of. So thank you very much.